Thank you everyone for joining. Special thank you to Connie, our presenter. This is a 6-part series on the student mental health. It's sponsored by Public Consulting Group. And just want to make sure everyone knows our presenters are not paid nor compensated by PCG to appear. We're all volunteering our time and expertise towards improving student lives. So the goal of this is not for sales, it's really for information and community building. So I want to just thank everyone for joining. Thank Connie for her time kind of preparing this slide deck for us. If you have an idea or suggestion for a topic or a presentation, please either enter it in the chat or feel free to email me directly at kbishop@pcgus.com. This meeting is being recorded, so we'll make recordings available at the end of this presentation. And as people are coming in, I've been trying to keep folks muted as they enter, just to cut down on the background noise. If you have any questions, please feel free to use the chat, and we will kind of take a break halfway through and a break at the end to address any questions. If you don't mind jumping to the next slide, please, Connie. Don't see the next slide yet. There we go. Just kind of a high level of who's attending. We have great attendance. We are actually up to 125 folks in the meeting today. So I think this is a really good attendee group that we got going, and representation from a lot of different school divisions and a lot of different states. Next slide, please, Connie. All right, and just kind of a reminder here, the Forum for Student Mental Health, we have a 6-part series. We're currently on the second one, and that says June 10th, but today is June 17th. Connie's going to be kind of talking through the Dallas ISD mental health reorganization. Our next session is on June 30th, going through the Salem-Kaiser threat assessment model with John Vendel, the author of Assessing Student Threats. And then you can see we have a couple more slotted up. There's the crisis intervention that we're looking to do on July 8th, equity and threat assessment on the 22nd. And on August 5th, we're looking to do a town hall on student mental health billing and reimbursement. Again, we are still looking to kind of garner more interaction. So if there's anyone that has an idea or has a way that they think could better any of these topics, or has a new topic to talk through, please reach out to us. Let us know. We'd love to get you included on one of these. With the housekeeping kind of out of the way, I'm going to kick this over to Rick to give a little kind of introduction and bio on Connie, and then we will turn the floor over to Connie.
Thank you, Kyle, and good afternoon, everyone. It's a privilege to introduce Ms. Connie Rodriguez today. She is the director of Dallas ISD's Psychological and Social Services. Ms. Rodriguez directs school-based mental health services to the district's 154,000 plus students. Her 30-year career includes development of crisis team response process for the recovery and stabilization of students and staff impacted by trauma, and leading clinical staff in delivering therapeutic and consultative services for students. Connie has also managed youth and family centers, which are Dallas ISD's school-based health clinics. In her past experience, she has provided family therapy in a community day treatment school. Ms. Rodriguez has also taught classes in physiological psychology, personality, organizational psychology, and health psychology as adjunct faculty at Texas A&M University Commerce. Please join me in welcoming Ms. Rodriguez today in our Forum for Student Mental Health, where she will share how Dallas ISD has reimagined student mental health services. Connie, it's an honor and privilege to have you today, and thank you for all of your hard work in preparing this material. I'll pass it over to you.
Okay, well, thank you so much, Richard, and welcome everybody. Thank you for taking the time today to listen to a topic that's near and dear to my heart. As we look at this conversation today, I want you all, coming from different backgrounds and different settings to realize that you're going to hear about a model that has been in place for some time in the district and that has gone recently through a reorganization, and some of the work that has gone into that, also some of the work that still guides us. Regardless of the reorganization, there's going to be a lot of things that will guide us going forward. Whether you're coming from a district that's rather small or rather large or in between, I hope that you're able to get something out of this conversation today that gives you something to think about as you're trying to formulate how you want to deliver school-based mental health services. So with that in mind, I want to give you a little bit of a background, contextually speaking, so that you understand how we came to be where we are today in this district. So right now, currently, our district serves 230 campuses, 154,000 students. One of our biggest obstacles is the miles in between. We have 384 square miles that we cover in this district. And it is the second largest district in the state and 14th in the country. So we have a large district by any measure, if nothing else, in square miles. And this is one of the hurdles or barriers that you have to address, regardless of what size of a district you're coming from. You need to look at who you want to serve and how you want to reach them. One of the next things I want to talk to you about is, again, contextually, I want you to hear some things. I've been talking about the models of services, of school-based mental health services for many years. And one of the things that people want to hear about is, from our district, is how are you all doing it? We've been doing this for a while. So I want to tell you, first of all, that we do have an advantage here in the district. One of them is that we historically have been, our mental health services historically have been supported by our board and by our school leadership over these many, many years. As you can see, we started back in the 70s, and over the course of time, as you see in this slide, our clinicians have basically been asked to serve and to expand the service. And over the course of time, you see that we've developed assessment instruments for suicide, for violence risk. We've brought in school social workers. We've addressed the crisis response issues that a school district of any size nowadays is going to have to address. And then we're looking at the last few years, the last couple of years, we've added a couple of little wrinkles to our work by adding mindfulness and what we call our behavior teams. Our mindfulness team is basically a group of clinicians who have studied this mindfulness topic extensively and are practitioners and use it both clinically and in their work with schools. Our behavior team as well. We have people who are keenly interested in the behavioral aspects of our work and have developed expertise around that. And they provide expertise internally to our staff and externally to the larger ISD community. So those are things that we've been allowed to develop and supported in developing by our leadership and by our board. And we've been, like I said, in place for many, many years. Our district has been extremely keen on this issue, so much so that about 20 some years ago, as a result of some of the work that was started in the psychological and social services, they came up upon the idea that we needed to develop school-based health clinics. And so currently now we have 12 clinics that are run by a clinic manager, that have clinicians there that offer therapeutic appointments and see families and students. We offer psychiatry services there as well. And one of our longstanding partners in this adventure of giving providing school-based health clinics is our local public hospital, which is Parkland Hospital. They are an original partner in this, and they have stuck with us and have helped us grow. One of the things that I want to talk about really briefly is, if you're looking at starting something like this, or you have an existing program, you need to look at what your mission is. One of the things that has really driven our work here is our mission to serve children. We've also sought people who demonstrate that in their work. That passion needs to be demonstrated in every aspect of their work. so that they can connect with people who are in a lot of pain and struggling. So that has to be communicated in every aspect of that work. One of the other things you need to look at is to make sure that your procedures and your processes and your procedures and your technology align to support your mission. If your technology is not in place and it doesn't support what you're doing, you need to rethink it. So that's important. The last thing I want you to look at is, at least for me, one of the things that I look at is, excuse me, wait a minute. There we go. One of the key features that we look at is, has the child re-engaged in learning? Has the child, is the child self-regulating in their emotional responses to the environment? And are we creating opportunities for acceptance and support within their families, within their school communities? Those are some of the three big key issues that we look at when we're trying to gauge, were we successful with our work today, with our encounter today? Did we help that child re-engage? Did they self-regulate? Were we able to get the support that they needed? Those are key features as you're looking at what do we want to develop? What do we want to create in our space? Over the years, one of the things that is really, and as I've presented this topic over different venues and to different audiences, I've had to help them understand what are the strategic practices that should guide you, whether that's in your hiring, whether that's in your workspace with clinical workspace, in every aspect, you need to have some strategic practices. I'm going to provide you with the ones that have guided us over the course of these years. We always need to look at strengths and abilities. There's no use in spending time as to what the child can't do or what the employee can't do. We need to look at what can we do and how can we make it happen. We always look at things holistically. Try to stay away from looking at things one-dimensionally. You need to look at the whole picture three-dimensionally. However you want to look at it holistically. Look at the problems that you're trying to address with your program that you're trying to set up. Look at it holistically. Always rely on your evidence-based, research-based. There's tons of research out there that you can go to that will help guide you. You don't have to reinvent the wheel on some of these issues. The other one that we look at is our leveraging costs, and I'll expand on that later in one of our other slides, but I want you to realize that you always have to look at how do you leverage, how do you position, how do you maneuver and strategize to get the most bang for your buck. And last but not least, literally, is do it with the least intrusive measures that you can. At the end of the day, we're working inside of a school system. And there's other work that is just as important or almost more important, and that is the education of children. So our work has to be very mindful of that. We're collaborators, we're partners, and we need to work with our educator colleagues to accomplish the mission of educating children as well. So I've talked to you about where we've been for the last 40, 50 years, where we've been recently. One of the things that occurred in this, and this is one of the things that brought this presentation to bear, is that in talking with colleagues over the course of time, one of the things that came up was our district has decided, you know what, let's re-envision what we're doing. Let's look at these two very well-functioning departments who are offering some great services, but we want to grow.
Connie, I think we might have lost your voice.
Let's try that. How's that?
There we go. You're back. Perfect.
Okay. So basically, the 2020, the February 2020 opportunity presented itself where we were asked to re-envision and reimagine what could our services look like together. If we merge these two departments that have been doing some really good work, how could we make the merger make a better and bigger impact? So here we are, February 2020, and we are looking at, now this machine won't let me click to the next slide, so let me see if I can poor little web, our broadband is probably not as broad as we'd like it to be. Okay, there we go. All right, so here's our next slide. Interestingly enough, it came up just by itself. All right, so as I was looking at this invitation to reimagine, one of the things I realized is that we were at an inflection point where we were being asked to either stay as we are and keep doing the same old, or look at a new way of looking at things, a new way of seeing things, a new way of impacting our services. So we've reached this inflection point in DISD in our particular part of the world where we're asking ourselves, what else can we do and how can we do it better? As we were looking, and I was looking at this incredible opportunity, one of the things that I was looking at, this old Albert Einstein quote that comes to me every so often, we have to look at problems from every angle. One of the things we have to look at is we can't continue to look at the problems from the same level of thinking where we were when they were created. So the opportunity to reimagine also gives you an opportunity to look at what else could we do, or how could we do different things or differently, so that we eliminate some of the problems in our system that our system is creating, perhaps. So that's one of the issues that you need to look at when you're devising a program that you're trying to impact mental health. So in our district, since we've been doing this for a while, one of the things that I looked at was our customer experience. For the last 3 years, our department in psychological and social services has been gathering data from the clinicians who are delivering the service. And every outcome, every encounter that they have is tracked. They track it and report on it. And so we've got a lot of data that helps us, and over the summer, every summer, we look at some of that data to see what can we learn from what happened this year. So I would totally encourage you, as you're deciding how do we want to do this, that you absolutely build in some way to collect data and be very mindful or very conscious of what data you want to collect. So in our district here, we've been doing this for a long time, and for some reason 3 years ago we decided we're going to look at some data from a different perspective, and that was an attempt on our part to make the data more relatable. So one of the things we always want to do is improve our customer experience, and that's where our data was. That's where I could get the clinicians really hooked into collecting our data. We've collected data every single time that they've encountered a referral and a request for service, and we've looked at that data to see what does it tell us about the things we need to change about how we do things, and how to deliver a better service. So one of the things that our data is doing is it's helping us look at the impact. What impact are we having at every single time that we are engaged, whether that's with an assistant principal, a teacher, a parent, a child. And as we're looking at this reorganization and reimagining of our services, one of the things we have to do is embrace change, but at the same time we have to preserve some of the things that have worked, continue to work, and will need to work. So how do we preserve that stability while embracing change has been the key piece in our work right now as we reimagine what we're going to do and how we're going to continue to work for the next 50 years or the next 30 or the next 3. So one of the things that this data has done for us is that it has really helped us hone in on the scope of our work, what we're doing, and how it aligns with the school district. So again, going back to your part of the world, as you're looking at starting something like this or expanding on something like this, you really want to make sure that your data collection has, it really informs your work. We have found that the encounter and contact data that we've been collecting, how we do, what we do, and where we do it, has been very, very useful to us on how we look at mapping our customer actions. So one of the things that it has told us is, here are the things that really work when we first encounter people. Here are the things that really work when we help refer that case on. Here are the things that we need to continue to do to support that work. So as we build this map, and it's not built yet, and it's actually very organic. This map is very organic. It has to be open to new data that feeds its growth and informs its growth. So I know that I'm focusing on data quite a bit, but we're at an age now in our technology environment where we can actually make data quite useful to us. One of the things that I remember vividly, and I've gotten this from various clinicians over the course of the last few years since I've been a director, is they come and complain, or they come and exasperated and go, how could this child have waited so long for services? Well, this is not new to this district. It's not new to any district. That's just the state of affairs in the field of mental health. One of the things that we're beginning to realize is that we're waiting too long to help people. So this great quote from Desmond Tutu just popped out at me, especially as we look at our data stream, our Dallas ISD, for being as huge as it is, has a lot of data. A lot of our larger districts, maybe even the smaller ones, have a lot of data on kids. So you need to look at your data and see how, what we're looking at from a mental health perspective is, how can we catch kids upstream before they fall into crisis? So everybody deals with crisis. That's not that we're not trying to eliminate crisis. I think that's unrealistic. But there are certain cases that come to mind, and every one of you sitting in your rooms and in your places of work realize that there are kids out there that you go, man, why didn't we catch that one so much sooner? So that's one of the things that your data can actually help. And when we looked at our data, here's some things we found. One of the big three discoveries from our look at our upstream data as to some of these cases that we've gotten is that one of the pieces that keeps our kids from getting services sooner is that there's still a lot of stigma surrounding mental health. So one of the things that we're going to try to develop here in the next few months, and we're trying to engage in, is how do we make mental health services as normal as going in and getting a checkup from a doctor? How do we make mental health services as normal as, oh, I've got a bruise on my leg, I want to go see the doctor? We have a real good connection with our medical field, where people feel very comfortable approaching a doctor and saying, hey, doc, I have a problem. We don't have that same sense of comfort with our mental health issues. We need to also increase student engagement, and this sounds like a no-brainer, especially in a school setting. But what I mean by that is that we need to help kids not just be in class, but be focused, be engaged in the work. And so whatever mental health services we provide, we need to provide it with that in mind. How do we help kids be better focused and better engaged in the work that they're doing so that they feel successful in that work? And last but not least, this is an age-old issue. I've heard this from the day I started my career back 30 years ago, and that if we can catch things earlier, we're going to be much better off. And I think I'm preaching to a choir of folks right now who are probably sitting here for this very reason. We want to catch these issues early and do something to avert the outcome.
Excellent. Connie, we have a couple questions that popped up. Can we take a quick break and kind of address some of those?
Sure enough.
All right. So just going to read some out from the chat. But the first question is here, do you collect outcome data, such as comparative analysis of mental health outcomes as compared to attendance, discipline, and academic records for students seen and or referred but not seen for mental health services?
We have that ability. We don't have the technology yet, and we're actually, one of the things that as we re-envisioned our service, one of the things that we're adding is a data analyst, because right now the only people doing that analysis is us. And it's a bunch of very geeky, nerdy people who are super interested in numbers. And because this district has done a really phenomenal job around collecting information, it's up to us to connect those dots. But we are capable of doing that, yes.
Excellent. And then I'm sure this is probably along the same kind of response there, but is data like dose-response relationship for students seen for mental health, is that another piece that you'll look at kind of capturing with that new role?
Say that again, I didn't catch that.
Sure. So are you also looking to kind of track or capture data on the dose-response relationship for students that are seen for mental health issues?
Yes. I mean, that's always been
Okay.
built in. That's always been built in.
Okay.
I think what we were looking at is more of what happened with those very frequent encounters, because we have two services. One is school-based and one is clinic-based. And the school-based service staff, as you're walking down the hall going to go get another student to go, tackle something, you're getting approached by other folks to ask about other children. So one of the things we're trying to do is capture all of those encounters as well.
Excellent.
All right.
I'll let you keep going then. Thank you for taking that short stop.
So a couple of years ago, there was a great article that came out in Child Trends. It's called "Are the Children Well?" And it really helped change this conversation in my mind around destigmatizing mental health. One of the concepts that they introduced was the idea that we set up a dichotomy, or we set up a stigma ourselves by talking about the mind and body being separate. And actually they're inseparable. And so this concept, and you can read about it. I sent this article along that you can read, and it can do a much better job. But essentially what we're looking at is that there are kids in our system that are very much identified already by their diagnosis that they have a mental illness. And then there's lots of other kids that are not identified. We tend to focus, perhaps even overly focus, on the kids that have the disabilities or that they have the diagnosis, to the detriment of the kids who are floundering. They're struggling. They're not ill, but they're struggling. And so one of the things we want to do in capturing that, going back to our Desmond Tutu quote, one of the things that we're trying to do is really catch these kids early in their evolution of their problems. The other thing we want to talk about, especially from the clinic side, is that there are many, many kids that are diagnosed with a condition and are managing their conditions pretty darn well. And so those kids don't need additional work. They need support to continue to manage their conditions. And so I think it's important to look at those two kids. We have the child who's diagnosed and doing well, managing, handling all of the obstacles that they have before them. And then there are other kids, obviously, that are struggling. And yes, that's exactly what those services are for. But we also have kids who are not flourishing, who are struggling. And we need to focus on them as well. And so this is the material that we're going to use as we go forward, trying to talk about destigmatizing the mental health issues. The other items that I've listed here, the self-acceptance, sense of purpose, autonomy, I've listed those for you to look at, because those are great goals to look at. And if you're looking at from a strength-based observation of students, you need to look at how are your kids doing in every one of these areas, and looking at each area and saying, how can we use sense of purpose for a student who is struggling to show up to class every day because things are not going well at home. They may have a sense of purpose around, I want to graduate. I want to be the first one to graduate. How do we use and leverage those things that they really have, they own, they accept, they have this vision of themselves. How do we use that to help them in their growth? The last thing I want to do and talk about in this particular topic is that I think every district now is looking at SEL and looking at how to support wellness at every level, because there are kids that are, like I just said in the previous slides, they're struggling, they have a diagnosable condition, they're managing it well, others are not. How do we support the wellness? How do we develop it, nurture it, design for it? How do we create design spaces in our buildings, in our classrooms to help support wellness? How do we replenish it? I know there's a big trend now, we're using it as well, where we have, parts of the classroom that are set up for the children to sort of self-regulate and support them in that skill set. So we've created those spaces inside buildings, inside classrooms, and we need to continue to do that. So now we've arrived at what are we doing? What is psychological and social services? What is this new service that we're reimagining? What are we looking at doing? Well, for sure, we're going to look at our data collection to guide our programming. You need to always have that in your mind, on your map, on your radar. You have to keep your data as part of that guidance system. You need to look at also, especially in a district as large as ours, but I don't care how big or small your district is, you need to always bring in your other departments and keep everybody informed as to what is happening within the limits of FERPA, within the limits of HIPAA, but also just guiding that, just collaborating and making sure that you're bringing them along. One of the very specific things we want to do in terms of efficiency and streamlining, we want to decrease wait time. We want to make sure that as soon as a student is referred, we get them into the services that they need. And that requires that we improve on our routing and collaboration on referrals. So when we have two different departments coming together now, we're going to need to look at how do we create a system that routes our referrals for us. And since we're living in a much more electronic era, we need to look at how we do that electronically. And last but not least is how do you decrease your caseloads so that you can really impact systemic change? Because our clinicians have other skill sets that can be used on a campus to help with systemic change. So right now, in this space and time, this is the referral process we have in place for both of these programs that are coming together. This is just one way of doing it. Everybody can come up with their own way. I wanted to give you just one, what one large district has done. Now, our crisis work is part of the school-based services, so we've included that in our referral process. But every school is different on how they handle and manage the crisis work. But as you can see in the center area where it talks about intake, how we route school-based concerns versus family concerns, personal concerns, and things like that. And so we're going to continue to operate as two services within one department. We're going to have a school-based service and a clinic service. So here's one of the things I mentioned earlier, and I think this is key to maximizing however many personnel you're going to be able to bring into the story of providing mental health services in your part of the world that you're coming from. One of the things that we started looking at about 6 years ago is how to look at teamwork. A lot of times it's super easy or super logical to say, well, we have a clinician, they can see kids, let's just park him here in this office space and let's just let him or her see as many kids as possible in a school day. One of the things we started looking at is how can teams deliver projects to impact systemic change? In our school district, we have an opportunity. Unlike a community clinic, we're partners with an educational system. And we have people who have a lot of experience. on how to impact systemic change. So some of our principals have reached out to us and said, hey, I really want to look at a grade level issue that has come up that has to do with behavior. And we have been able to come in and help them with those issues. And we want to continue to be able to offer that so that we can maximize the expertise that the district has hired. The other thing we want to look at that is really super important is to look at the quality of the therapeutic intervention versus just an arbitrary number of sessions. There's nothing more wasteful, I think, than to say, well, we're going to do 6 sessions or we're going to do 3 sessions and that's it. I think you need to look at did your child, that the person that is being asking for services, did they get what they asked for? And did they get it in 2 sessions or 3? If they got it in 3 sessions, great. There's no need to make more than that if that's what's going on. So be very mindful of the quality versus the quantity. The other thing we started doing, because some of our cases can become quite complex and a lot of information gathering has to happen rather quickly. One of the things we started doing a couple of years back is pairing up clinicians to tackle complex cases, especially ones that were causing a great deal of alarm or worry at the campus. And it might involve a child that arrived 2 days before where they didn't know the story behind this child, but in this particular setting, they're having quite a bit of distress and it's worrying everybody. So one of the things that we started doing was let's mobilize some of the staff to really start addressing that at in a very meaningful way for the campus. Couple of years ago, I think it's going on 4 now, several of our staff became very excited about the work that was being done with adverse childhood experiences and the trauma research that was out there, and started going out on their own to get that training, and came back and said, can we bring more of this training to our department? And sure enough, we were able to do that, and we have been supportive of that. But if you are going to begin this work, if you've never done it and you want to begin, please make sure you put on your radar and your to-do list to make sure that you get trauma-informed therapists in your workspace, because that is an issue that is common in every school district. I don't care if you're rural or urban, that trauma issues are evident in every aspect of the work. Last but not least, with leveraging costs, one of the things that tends to happen in our work, because we're itinerant, we travel from schools to school, we serve 1 to 2 or 3 schools a day, perhaps, maybe, but at least 2 schools a day. One of the things that tends to happen because of the work, it tends to create a sense of isolation. So one of the things that by leveraging this a way that we talk about and use our staff, we try to really open up that space so that people don't feel like that they're by themselves trying to resolve complex or difficult cases. The last thing we want to do that this does for us is it increases the empowerment of the clinician. If we empower our very well trained and passionate, they're incredibly interested in serving our kids, the last thing you want to do is tie their hands up. So one of the things that we've always looked at is how do we empower the clinician to really tackle a problem. So let me just give you a quick example. One of the clinicians came to me and said, I've gotten like 30 referrals out of this particular school, and it all seems to be related around this issue. And I said, so what do you want to do? Because you're just the one person. She says, I really want to look at some systemic issues. Can I do that? And I said, of course. What do you need? We provided her what she needed. She engaged with the administration of that campus. They welcomed that observation and the collection of that information, and she was able to help them pinpoint how to decrease the number of referrals in that particular of that type. So that's the kind of empowerment I'm talking about. Well, now we've come to every one of us is facing what COVID-19. March 2020 was a life-changing month for every one of us in this talk. All of us are facing, in one aspect or another, the aftermath of the COVID-19. So one of the things that COVID-19 has done for us, I think, as well as with a lot of people, is it's exposed a lot of problems. But one of the things that it's done on our end is it's really helped us accelerate on some solutions. So as you look at this COVID-19 and its impact on your district and in your workspaces, wherever you are, you really need to focus on your people, culture, and processes that create solutions. You want to look at this is a terrible, terrible thing that's happening across the world, but how do we find a way to make it work? So we need to adapt to this changed environment, and there is no going back. I was just talking with one of our folks the other day, and we were like, yeah, that day in March before we went on spring break, we will never really go back to that space. Our space, our future going forward is with COVID-19 as part of our, it's a barrier, and it's something that needs to be addressed, and it needs to be faced. So our district, and in psychological and social services in particular, when we were looking at this issue, and our sister department, our youth and family centers, when youth and family centers and psychological and social services came out of our spring break, one of the things we started looking at is what were the internal and external resources that we needed to develop or find to address this sheltering in place and doing our work remotely. We immediately became really good at the video conferencing platforms. We found which ones worked for us, which ones didn't. And one of the incredible pieces of work that I think we did in a short amount of time is developing electronic consent and referral processes that had not existed before COVID-19. Before we went into sheltering in place, before we went into this, we were always word of mouth. We were always filling out referral packets to youth and family and things like that, but we didn't have this piece in place. So interestingly enough, this is one of the opportunities. This is one of the things that happened. The other thing is, in the space of about a week and a half, we had all of our therapists, all of our clinicians, trained in what we would be using, which is teletherapy. And the last piece you have to come up with as you work remotely is, how do you account for what people are doing? So in our first couple of weeks, we were doing lots of webinars just to make sure people were up to speed on how to do the teletherapy, and what are the risks, and what are the benefits and risks of the teletherapy environment. And that's one of the things that we had to track. So right now and going forward, here's how mental health services is going to exist. We're going to exist as a clinic service, a school service, and a telemental health service. And both sides of that, both clinic and school, will be able to continue to conduct telemental health services. And that's important because that was never on our radar before COVID-19. Our future needs, we're going to need to make sure that our virtual platforms do support the HIPAA and FERPA. We've already been looking at that. We've already engaged in that. But if you're trying to decide whether you're going to engage in a school mental health program for your school district, you really need to keep that in your mind as you go forward. Let me just give you a heads up for those of you that are not clinicians. One of the things that drove a lot of our people, a lot of our professionals crazy, was the limits of confidentiality and adapting our service. Because if you think about it, telemental health had existed prior to COVID-19 almost exclusively in the adult mental health field. When it became time to provide mental health services for adults, one of the areas that was really being advocated and used, especially for rural services that didn't have a lot of clinicians, is to create those telemental health portals. Well, now because of COVID-19, because of the sheltering in place, because of this situation that we're in, we're now having to expand telemental health to include K through 12. Now, for the secondary age student, that's not as big of a problem. Most of those kids can make that shift. Where we are really working and trying to develop some additional resources in is for that K-5 group. The other thing that we're having to develop is our crisis response and how it looks in this remote virtual world. We've actually had to do crisis response virtually, and we've learned some things that have been very useful. But again, we're going to have to gather more data around that to see how did it accomplish the mission that we intend. Because one of the things we want to do is restabilize people as a result of a crisis. And if our remote work is not doing that, we want to know why and how to fix it. So we are here. Yeah, I guess.
All right. Thank you so much, Connie. I have a couple questions I was going to read through right now.
Did I get overtime? Okay.
Can you hear me okay, Connie?
I sure can. Go ahead.
Excellent. So first question I was going to just ask you about is, are you conducting universal screening in Dallas? And could you talk a little bit about kind of how you're handling that if you are?
The universal screening question has come up over the years, and there's a lot of pros and a lot of cons. One of the problems, the way we handle it at this time is that we look at the adults in the system, whether in the school, in the classrooms, in the campuses, and the parents. They're our screeners. They're the ones that bring us our kids and say, I'm worried about this child. Something doesn't seem right. So we don't use a universal screener. We use adults in our system, and we educate the adults on what is normal development, what are some risks and warning signs for assistance around mental health. And so we train the adults as sort of our surveillance system. So the cons against screening is that what do you do with one of the issues I've had is the false positive identification of students. What that means is identifying students who don't have a problem, and so you're burdening the system with kids that don't have any real need at that point for a mental health service.
Great, thank you. Just a couple more I'm going to kind of run through here. What would you say are kind of the most common diagnosed mental health conditions that you're seeing and treating?
Well, it depends on the age group. What we're seeing at the elementary age is the externalizing behaviors. That's what the common term is, externalizing behaviors. Basically, kids who are disruptive. You don't tend to see that in the secondary age group from probably age 12 on. The more common things there are kids who just don't show up. They're literally not showing up or not engaged, if you will, in school. And so these are kids that are suffering from depression, anxiety, and things like that. They're internalizing. And some of those kids have gone under the radar. Nobody has seen it. And we're now finding them at this point.
Gotcha. Okay. And then kind of staying on that age thread, are any clinicians or are you recommending any of your clinicians use the ages and stages questionnaire, the BASC-3, to determine improvement in children's mental health?
We have used the BASC, or we use it. We use it as a screener once a child has come to our attention, either by referral from a teacher or a school administrator or whoever, a parent. We will use the BASC as needed to determine what is sometimes it's about establishing a baseline as to, we know what the problem is, we just need a baseline. In other instances, we're not clear about what the problem is. is this an externalizing behavior that's due to an attention deficit issue, or is this an externalizing problem that we're seeing that's related to an anxiety? So we need to sort some of those out, and we'll use the BASC to do that.
Mm-hmm. Great. And then kind of just looking at the Senate Bill 11 and threat assessment and all the work under that, could you just talk a little bit about how that guided or aligned to your shift in the model, if it did at all?
Well, I don't think it changed. Well, this goes back to that other slide where we are, embracing the change that's happening, but we're also keeping some things in place that need to stay in place. We have a threat assessment process that has been in place since the 90s, and it has been very helpful to us in identifying kids and getting them the resources that they need. So one of the things that Senate Bill 11 did is it just brought even more attention to the need for mental health services. Not that our processes have changed so much, but that it just goes one more step further and really emphasizes why school districts need to have a mental health service.
Excellent. And then kind of one more question for you. Are the school-based therapists assessing, diagnosing, and treating the mental health conditions?
The school-based and the clinic-based have two different roles. They're diagnosing only to the extent that it's useful in coming up with a plan of action and a treatment. So if we're looking for a child in an elementary age group that is externalizing, is exhibiting externalizing behavior, they're disruptive. One of the things we will look at is this an anxiety-based issue or an attention issue, or what is it exactly? And then based on that, it guides our work. It doesn't do any good to just say, well, we're just going to reduce the frequency of disruption if we don't know why it's happening.
Mm-hmm. Excellent. Just kind of scrolling through. I think I've highlighted all the questions, some of the questions you answered through your presentation, so I'm not going to rehash all those, but definitely appreciate the questions coming in. And Connie, of course, we appreciate your time. I'm going to give kind of one more minute, just last call if there's any other questions that come in, and then we'll take it to the closeout.
And I'll send you the material that I have on inflection point, and so that you can, if somebody asks for it, you can provide it to them.
Excellent. Thank you so much. And one more question just came in. Is it true that half of all mental illnesses begin by the age of 14 and 3/4 by the mid-20s?
That's what SAMHSA has been reporting for some time, and that goes to, anybody that works in this field, that we are sometimes heartbroken by the fact that it takes so long for somebody to access services. And so it's some of that, to me, has got nothing to do with mental health stigma so much as just accessible and affordable services. So any district out there that is really looking at this issue, I really applaud you, because I think that if you can increase the access of mental health services in your school district, I think you're going to see some really improved outcomes for your kids, both educationally and mentally, and holistically speaking, you're going to have a better graduate, if you will.
Excellent.
Great, Kyle. If you could maybe go ahead and end it up on the future session slide, I would like to, if you don't have anything else, Kyle, I'd like to take the floor for a moment.
Sure, I'll pass it. Kind of, if you don't mind advancing one more slide, and we'll let Rick kind of close us out here.
Yeah, just want to thank everyone so much. We're 3 minutes to, and Connie, the work and effort you put into sharing all of your work is so appreciated. Just looking through the list, I see so many friends, and just a wave to all friends, old and new. It's an honor to have you. This idea came about a few weeks ago, and I'd like to thank my boss, Dan Wisman, for endorsing the idea and supporting us. the entire way. So Dan, thank you for your leadership in this area, and thank you for letting this idea flourish. 180 people at one time were on today. We're absolutely thrilled. And if I could, just to get a raise hand, if you look in the bottom, you can raise hand. If you've got something of value, or this was a very good, effective use of your time, just some feedback for Connie. If just a raise hand down the bottom that says, I'm so glad I came, I would appreciate that. And I know Connie would from Dallas. Thank you so much. We are looking for presenters in our last two. We've got 3 sessions coming up where we still need presenters, remote crisis intervention. If you have expertise there or would like to volunteer someone, I see the hand raises come in. Connie, 32 people so far saying they've enjoyed what you've had to say, and they're still raising their hands. So thank you all. Keep those coming. Tell someone about our Student Mental Health Forum. We're a 6-part series. June 30th, author, psychologist John Van Driel will be speaking to Salem Kaiser and how he developed a community-based threat assessment model in his city some 20 years ago. It's now becoming one of the de facto standards models of implementing threat assessment in a community-wide context. We're delighted to have John come on June 30th. And then July 22 and I think the 8th, and then August 5th, we wrap up with a very important session on mental health services billing. How can you get support perhaps on certain things? And there's a lot of legislation, ifs and conditions with that. So you won't want to miss that session. So Kyle, great job today. Again, honored, Connie, to have you share with us, and thank you so much to all of you out there, and thank you for the positive hand raises. Kyle, I'll pass it back to you for goodbyes.
Great. Thank you, Rick. Thank you, Connie. Thank you, everyone, for the time. And we will be following up with some information on just some of the documentation that Connie spoke of. And if you, of course, are interested in getting on any of the future forums, if you have something you want to talk through, if you just want to make sure that you're included as the next session comes in, please feel free to reach out to myself, kbishop@pcgus.com, and I will be sure to add you to the series. Thank you so much.